Buon pomeriggio a tutti, direi.
Good afternoon, everybody. We can start our session again. Welcome back. Today, in the morning, we presented the details and a summary of the ProCare project. While in the afternoon, we're going to have some short communications. And the idea is to share some results of researchers, of colleagues who are involved in research projects, and they are the result of a call for abstract that we launched at the beginning of January. We distribute it across the whole region, the country, and internationally as well, thanks to the collaboration with our Slovenian, Spanish, and Irish partners. We got lots of abstracts. We selected them for the presentation of today. We have 14 of them. Unfortunately, there is a colleague who is not available. She is ill, so she cannot get connected remotely. The purpose of the call for abstracts was to gather together experiences of collaboration between universities and hospitals, so that it is possible to share new knowledge. And we're also going to talk about experiences of our colleagues who work in the clinical practice, so they can talk about the outcome of their researches. Inside the folder, you saw that we have numerous posters, and you can also view them using the QR code that you can see here. And there were about 50 people today in the morning who were connected remotely from Italy, Slovenia, Spain, and Ireland. The first presentations concern research experiences in the clinical sector, so in the field of hospital management, pediatric care, and palliative care. And then education, and I'm talking about basic education and continuous education. The first contribution is by Matej Bahun from Angela Bonskin Faculty of Healthcare in Slovenia, and I would like to give the floor to her. And I would like to remind all of our colleagues that we have 10 minutes each. We have 2 very intense hours, but we wanted to give the possibility to everybody to present their experiences. Thank you very much. The floor is yours.
My name is Matej Bahun, and I will present nurse-reported job characteristics in accordance with their practice environments in Slovenia. This work was done by Professor Brigita Skelasavic, Professor Walter Schermaus, Simon Delo, Professor Alison Squires, and Professor Bojana Lube. And a little bit of a theoretical background. Nurses' work environments play important role in their ability to provide good nursing care. And good environment is crucial for maintaining nurses' health, job satisfaction, and also occupational safety. And nurses' job satisfaction and satisfaction with work conditions significantly impacts their efficiency of nursing care, and also very important affects patient outcomes. And inappropriate working conditions are result of underdeveloped infrastructure, poor working organization, inadequate education, and inappropriate staffing norms. We talked about situation in Slovenia. So all these hard conditions that nurses face in Slovenia are factors that had a major impact of the professionalization of nursing and its development as a science in Slovenia. The aim of this research was to present cross-cultural adaptation of the Slovenian practice environment scale of the nursing work index and to explain this subscale of factors with job characteristics of participating nurses. This research was part of registered nurses forecast study in Slovenia, as Katja before mentioned, as a part of ProCare project. It was a cross-sectional explorative research and was conducted in 8 of altogether 10 general hospitals we have in Slovenia and both clinical centers that we have. We gained permission of National Medical Ethics Committee, as we should, and Slovenian version was prepared in 4 steps with content validation by panel of experts and pilot testing. Altogether, there is estimation of 2,813 nurses in medical and internal wards of those hospitals I mentioned, and response rate was 36%. That was 1,010 nurses. And as you can see, 40% registered nurses and 60% nurse assistants. Well, results show that overall composite scores show our environment of those nurses as favorable. But if we look at the data from other researchers, we see that Slovenian data is among the lowest of all data in previous researches. So really, nursing work environment is not as good as it is seen at the first glance. The highest partial agreement with these statements that are written here. So a nurse manager who is good manager and leader, working with nurses who are clinically competent, a nurse manager who backs up the nursing staff in decision making, even if the conflict is with physician, working with nurses who are clinically competent, and collaboration between nurses and physicians. And all those statements describe support from managers and physicians. And job characteristics that are the most highly rated are satisfaction with current job, career, and work environment. This is like data in a nutshell, so I'm trying to be fast. But regression model explained the 5 factors between 26 and 47%, and the strongest explanatory variables were opportunities for advancement, educational opportunities, professional status of nurses, and satisfaction with current job, work environment, and independence at work. So, just to sum up, results show still poor performance of managers in ensuring adequate staffing levels. As we heard before, we really struggle also, like other countries, with staffing in nursing. Poor involvement of respondents and managers in hospital affairs. So voice of nurses is not always heard as it should be. And also poor development of promotion opportunities in nursing in Slovenia. Cooperation and relations between doctors and nurses, the promotion of nurses, and the quality assurance programs are below international levels. And we find still a lot of biomedical view on healthcare in Slovenia. So this ineffective and non-existent collaboration leads to decreased empowerment, increased burnout, decreased job satisfaction, and increased turnover among nurses. And I was looking at some data, and I saw that like 30% of those nurses, if we ask them if they would leave their job in next year, 30% say yes. And of those 30%, half of them says they would not work in nursing anymore. They would go somewhere else to work outside of nursing profession. That is quite a lot of nurses that think like that. So creating an optimal work environment for nurses is an important task of managers and leaders, and also national healthcare policy. Understand nurses as an equal healthcare professionals and nursing as profession and science. And we found that nursing and we found, so it is time already to finish. And okay. Thank you very much for that. And we found that nursing leaders support nurses, but they don't have enough competencies to argue for the importance of skills and staff development in nursing. That is so in Slovenia, and probably somebody else is also struggling with that. And education and development of leaders in nursing is still very much required as on the front line to improve things. So that is all. Thank you very much.
Grazie Matej anche per i...
Thank you very much, Matej, also for the timing. So we will keep some minutes in the end for a final discussion on the different contributions. Now I would like to introduce our colleague Javier Gonzalez from the University of Alicante, who is already connected.
Good afternoon, everyone. And my name is Francisco Gomis. I am from Spain, University of Alicante, and today I will talk about the following work. The title of this work is Improving the Pharmaceutical Care in Spain through a collaborative approach, filling the gap between theory and practice. Next, please. Thank you. Nurse prescribing in Spain as a part of the European pharmaceutical care strategy is a transitioning towards its implementation in the different regions in Spain. The approval of the Royal Decree and based on clinical practice guidelines and protocols. Literature published until now highlights the importance of interprofessional collaboration within the health sector towards achieving success in such transitions, as well as building bridges between theory and practice, understood as a collaboration between higher education institutions and health organizations. In line with this, we aim to create a framework based on the improvement of pharmaceutical care in Spain through the collaboration of the different health professionals, physicians, pharmacists, and nurses, and other disciplines, such as the technological ones, and the consensus of both the educational file and the healthcare practice. Next, please. Particularly, our objective consists of developing specific pharmaceutical care education and training for nurses in Spain, with a special focus on nurse prescribing by consensus of experts from different universities nationwide, as well as to develop technological solutions for nurses supporting their competencies and responsibilities on pharmaceutical care and nurse prescribing, based on the current patient safety policies. Next, please. On the one hand, we will conduct a modified Delphi technique with national experts on the topic towards reaching consensus regarding the contents of the training. And on the other hand, we will design a technological tool based on artificial intelligence algorithms using the standardized protocols that support the nursing professional prescribing, and that is based on patent safety. In both methods, the clinical guidelines on the types of medication included in the Royal Decree will be used. The training model for nurses regarding pharmaceutical care and nurse prescribing will be adaptable for both the university nursing training by completing the gap currently existing in the study plans in relation with prescription and to the continuum training of professionals in practice. This module will be deployed after identifying and reaching consensus on the content in the file of nursing and pharmacology. Experts will be faculty, staff from different Spanish universities and also from foreign universities in countries where the nurse prescribing has been implemented for years. Subsequently, the module will be deployed with students and professionals, and later an evaluation will be conducted with regards to its usefulness for prescribing through the technological tool. Next, please. The technological tool will be designed not only to follow up patients' medication management from the nursing prescribed, but also to send patients and safety advice regarding the medication they are taking, recommendations, notes relates with prevention, education, and promotion. On the professional side, the technological tool will allow those using it to continue themselves in terms of educational items in pharmaceutical care and nurse prescribing. Through the access from a computer or mobile device that will provide the nurse with an interface on which to really when prescribing medication to their patients safely. The application will also direct control professional user contact and will favor the prevention of possible adverse effects and potential drug complications. Early detection of errors and unwanted situations related to prescription and administration of drugs, as well as the promotion of healthy habits and education for the health in pharmacological matter. Next, please. Below, you can see systematically the characteristics of the application. The web application can be managed by nurse, and this way she will, on the right side of the main menu of the application, a timetable with the pending appointments of the day, and on the left side there will be a section oriented to his training and to complement his knowledge about the prescription and the medicines that works with. Communication between three parties, the nurse application, the patient application, and the server with the artificial intelligence system will be carried out through the internet. Next, please. And this is the references that I use to work. Thank you very much.
Grazie per questo contributo.
Thank you so much for your contribution. Now let me introduce my colleague from the Azienda Sanitaria Universitaria Friuli Centrale, Simonetta Grubissa and Arianna Tovoli.
Everyone, I'm Simonetta Grubissa and I'm an IBD nurse, and with my colleague Arianna Povoli we are going to talk about inflammatory bowel disease nursing in Italy, the experience of the University Hospital of Udine. First of all, what are IBDs? Inflammatory bowel disease is a term used to describe ulcerative colitis and Crohn's disease. Both are chronic conditions characterized by ulceration and inflammation in various sections of the digestive tract. Common symptoms include diarrhea, often with blood and urgent, abdominal pain, fever, fatigue, and weight loss. IBDs are often associated with the so-called extraintestinal manifestations, which may affect joints, skin, liver, kidneys, and eyes. For these reasons, different healthcare professionals are involved in the care of IBD patients. We distinguish two different categories. On one side, we have a core team in which we found gastroenterologists, IBD nurse, surgeon, radiologists, pathologists, and specialized pharmacists. And on the other side, a complementary team with a dietitian, psychologist, nephrologist, pediatrician or general practitioner, a rheumatologist, dermatologist, ophthalmologist, and infectious disease specialist. But the key role is played by the IBD nurse. She provides expert clinical care and manages patient condition through, for example, a telephone call or email support addressed mostly in case of flare-ups or symptoms getting worse. The IBD nurse takes part in follow-ups clinic, guarantees rapid access to the clinic for the patients that require a visit, offers support for patients that need surgery, is responsible in administering and monitoring of biological therapies, and is involved in clinical research addressed to screen patients for randomized and controlled trials. How did I achieve my competencies in IBDs? Through a formal training organized in 2018 by the University of Udine, named IBD Nurse Case Manager, lasting 200 hours. And what is done in IBD clinic? Gastroenterologists diagnose IBDs with endoscopy, prescribe treatments to reduce inflammation, and plan clinical follow-up. Please, Arianna.
We conducted a retrospective observational study. All patients who attended the IBD clinic for the administration of biological therapies, gastroenterological visits, training for subcutaneous therapy administration, follow-up for clinical studies, also via calls or email, were included. Data were collected from the 1st of January 2018 to the 31st of December 2021. A total of 1,114 assessors were admitted to the IBD clinic, and the mean age of the patients was 45 years. We will analyze the trend of the following 5 categories. The first one is the outpatient visits, where 701 in 2018 and 679 in 2019, while 639 in 2020 during the COVID-19 pandemic in 2020, and 708 in 2021. From 2020 to 2021, there was an increase of 11% in activities. The second, the number of drug administration increased by 34% from 2018 to 2019. Also, these endovascular therapies were not affected in 2020 and in 2021. The number of training sessions for subcutaneous therapies decreased by 50% from 2018 to 2019, then the number increased by 34% from 2019 to 2020, and by 134% from 2020 to 2021. In 2020, virtual visits were implemented with an increase of 458% of phone calls in 2021 compared to 2020. The clinical studies, invece, follow-up appointment for clinical studies decreased by 60% from 2018 to 2019, but the number increased by 100% from 2018 to 2020 and decreased by 20% during the 2021. Data gathered in the study show how qualified nurses can improve IBD pathway and increase the activity of IBD clinic with high standard treatments quality. Furthermore, factors such as motivation, sense of fulfillment, and willingness to continue formation have been found between the nursing staff. In conclusion, the collaboration between the University of Udine and the Hospital of Udine proved encouraging results that can be replicated in the similar context.
Grazie ad Arianna.
Thank you so much, Arianna and Simonetta. I would like to invite now Francesco Cecchini, working at the Azienda Sanitaria Universitaria Giuliano Isontina in Italy. Please, you have the floor. Good morning, everyone. It's quite challenging for me to be here. I would like to thank you so much. I would like to greet you all, dear colleagues, and our Professor Palese, specifically the role of the nurse, the expert nurse in the education for the prevention of ulcer recurrence in our patients. So let's see what this is all about. So this problem is quite a critical problem, the recurrence of ulcer in diabetic foot patients. So the object of our work is to evaluate risk and prognostic factors for recurrence in diabetic patients with previous ulcer. The purpose of this study is to evaluate these factors for our patients. What about the methods? The follow-up analysis from September 2018 to November 2018 at the Diabetes Care Center of Monfalcone, the Hospital of Monfalcone here in our region. We identified 50 patients with recurrence after previous ulcers and 33 patients with previous lesions but without any recurrence. The study represents most of the patients with diabetes of type 2. So a type 2 diabetes, an average of 68 years of age, overweight with average BMI over a value of 30, and an optimal metabolic control. I beg your pardon. The kidney function on average was the one you see here, 7.8%. The group with recurrence compared to group without recurrence presented similar age, diabetes duration, and metabolic control, BMI, and renal function. Prevalence of neuropathy, vascular disease, and ischemia were not statistically different into the two groups. What about the results? Data in this study highlighted that recurrences were usually multiple in 92% of cases and localized at toe level, 70% of cases. 80% of patients with recurrence presented a low level of foot deformity limited to the forefoot with a maximum loss of 1 metatarsal head, while 20% presented charcot foot, deformity of rear and middle foot, or severe deformity. Orthopedic shoes were prescribed in 66% of cases, but compliance to use was low only for 17 patients, 34%, using orthopedic shoes more than 6 hours per day. The absence of compliance increased the risk of recurrence despite adequate shoes. Direct causes of recurrence were traumatic events in 20 patients, and conflict with shoes was traumatic in 27 patients. Analyzing risk factors, multivariate analysis found that compliance is a protective factor, no matter the age, diabetes duration, deformity level, and gender. So going to conclusions, ulcer recurrence is a common event in diabetic patients with previous lesions. Data from this study evidence that recurrence is usually multiple and localized at toe level. Compliance is the key element in prevention, resulting protective independently of other factors. Nurse activity play a pivotal role in identifying patients at risk, targeting the education and evaluation of compliance. Thank you so much. Thank you so much, Francesco. Now I would like to invite here Raffaella Dobrina from Burlo Garofalo in Trieste, Italy.
The opportunity. I'm here to represent a group of nurses from my hospital, from the operating theater. The title of our study is Nurses' Perception of the Preparation and Informational Support Needed for Patients and Children Approaching the Operating Theater, a cross-sectional qualitative study in a maternal child health hospital. So this study originated from some critical thinking of this group of nurses about their practice in the operating theater. In this hospital, parents are welcome to accompany their children in the operating theater until the induction of anesthesia. So this group of nurses started thinking, why are some kids' anesthesia induction easy and some are not, besides the presence of the parent? And how can we avoid distressed parents to distress their children? And how can we improve children and parents' comfort in the operating theater before an anesthesia? And how can we maintain the safety of the environment when parents are around? So let's see what we have in literature. Well, actually, parental presence in the operating theater is a controversial issue. As for example, in Sweden, in a national survey they did, most of nurses were very positive about the presence of a parent because they found it useful to comfort the child. While differently in randomized controlled trials, in some studies they found when they compared the presence of a parent and in the experimental group and in the control group, no parent, they didn't find much difference in what, they didn't find a statistically significant difference in what was the child anxiety or the parent anxiety. The same happened for other studies where they compared doing some education to the parent and to children through videos or virtual reality tours in the operating theater. They haven't found any difference with the control group, or they didn't have with the standard care. So that's why the aims of our study were to further explore the experiences of nurses concerning family presence in the operating theater until the induction of anesthesia, to identify the topics and best approach of education to be provided to parents and children facing surgery, and to explore the barriers and solutions to family education and safety in the pre-operative process. So the methods we chose was a qualitative descriptive cross-sectional study design, and we chose the focus group method. And the questions that guided the focus groups were, What is, in your experience, regarding the presence of parents in the operating theater next to the child before anesthesia induction? And in your opinion, are there any aspects that could be improved? Which ones and how? Our study period was in 2021. We performed a content analysis of data, and we obtained ethical approval for the study. So we did 2 focus groups in total for a total of 12 participants. And content analysis, through content analysis, we extracted 3 themes and 5 sub-themes. Theme 1, parents' responsible presence in the operating theater. All participants agreed about the critical role of a parent in supporting the child's needs. However, a nurse said, while we're putting in the venous access, the parent role is to play with the child to distract him. But if the parent watches what we're doing, the child will watch what we're doing. So this is not working. Some nurses, for some kids that are adolescents or older kids, they ask them if they want the presence of a parent in the operating theater. And the nurse said, I asked the child if he wants his mother to accompany him or not. If he prefers to go on his own, it is important that his mother respects his wishes. Many mothers agitate their children, and the children seem to be aware of this. But the parent needs to be supportive on the decision-making of their child. This is what the nurses found important. And then the nurses found important for the parents to be compliant with safety standards of the operating theater. A nurse said, I need them to be collaborative and not touched around. There are clean and sterile areas that need to be preserved so. Another theme extracted was critical issues, and one pertained critical issues in engaging parents. A nurse said, the operating theater is an unsuitable place to provide education because parents arrive there very anxious, so they seem not to listen to what you're saying. And so they say preoperative visits don't, unfortunately, include an operating theater nurse while we should be there. Then another nurse said that sometimes they do all they can to provide education, but sometimes it's just the anxious nature of a parent. We see them coming and we already know how the induction will go. Another critical issue was children's lack of information. A nurse said, it seems incredible, but some children arrive not informed about their surgery. I had a parent who came to the operating theater and told the child that they came here to take pictures. But this group of nurses also provided some possible solutions to these issues, and they found that education was the main solution. So educating who and what. And first of all, it was important to educate children. And one step could be, by showing them all the things that they use and that they have never seen, such cables, saturometers, monitors, involving them in the environment they are, would make them very comfortable. And also, they said we should spend more time in helping these parents to understand the importance of their role in supporting the kids and informing their child, because sometimes they do real barriers, even for nursing staff, to inform the children. They want to protect them, but this way it's not useful, and they don't provide comfort. This is what they found from their experience. Oh, and one last thing, they also said that they could provide education, since they cannot, for organizational issues, maybe they cannot put an operating theater nurse in the pre-visits before surgery, so maybe they could educate some nurses from other wards, from the surgery ward, to inform parents. And also they suggested that to overcome organizational issues, they could prepare some videos to show to families, or, this was something new from literature, do some platform meetings with a group of families and organize this meeting and try to, open to questions for parents or children as well. No. one more. So, what was consistent with previous literature is that parents' anxiety in the operating theater worsened children's perception of their experience. So, to contrast this, to control this, it's very important to empower parents and make them aware of their role in providing children comfort. And something new from literature was to make parents aware of their body, where they're watching, if they're fidgeting, and touching areas. And then engaging children in this new environment. And this was, we found something very interesting in a study where they gave children, before entering the operating theater, some masks to touch, or some things that could make, to desensitize them about the equipment in the environment. So, findings of our study laid the foundation for building an educational program for parents, children, and nurses from other wards, even through its platform. And we thought about doing a study, maybe through an platform meeting, to try to see how it goes, if parents like this kind of education, if we don't have other occasions to meet them. And then further studies exploring parents and children experiences and educational needs in the operating theater may better focus also educational contents. And we started a study in this as well, but we only enrolled 7 parents. And what we found is actually that they don't have any informational needs besides what the information we gave them. So maybe from these first findings, they're not aware of what they might need to know. So we hope to have another occasion to give you further results. And thank you.
Thank you.
Grazie Raffaella.
Thank you so much, Raffaella. Now we have Simone Macchi. He's working at the HEIs, Istituto Nazionale di Tumori in Milan. Simone Macchi, you have the floor. Just a couple of minutes for the remote connection.
C'è intanto qualche domanda?
Is there any question? Questions, suggestions? Don't be shy.
Anche rispetto ai contenuti.
Also about the contents of the morning, if you want to better analyze some details of some topics.
Posso dire, molto interessante.
Well, the first speech of the afternoon was really interesting. The importance of the working context. Do we have the colleague? Can you hear me? Yes, we can. Okay, let's give the floor to the colleague. Thank you so much. We cannot see you, unfortunately. Can you see my slides? No, we can't. Now we can. Can you see my slide? Yes, we can see. Okay, we can start then. Yes, we can. We have Simone Macchi and Elisa Balbone connected for this speech.
And I work with my colleague Simone in the pediatric oncology.
La sentiamo poco.
Mi scusi, si avvicini al microfono.
Could you please come closer to the mic? We cannot hear you that well.
Experienced by adolescents with cancer doing chemotherapy.
Non la sentiamo.
We cannot hear you. We cannot hear you. Please, please come closer to the mic.
intense and then to be chemotherapy protocols. This adverse effects can cause many physical and psychological issues that negatively impact the quality of life of including their ability.
Non ci sente, sta provando anche il tecnico a contattarla, ma...
Così sentite meglio.
Well, there's a bit of an echo. We cannot hear you that well, but it's a bit better. Can we go on? Let's try if we can hear you. We couldn't hear the colleague.
Many physical and psychological issues that negatively impact the quality of life of adolescents, including their ability to engage in common activities essential to their development. Therapy-related adverse effects were more frequent and in adolescents when years as expressed by patients in their assessments, symptoms were the occurrence of symptom does not higher severity or the aim of our study was to find the occurrence of symptoms with particular attention to their frequency, severity. Data were collected from January 2000 to January 2006 at Istituto Tumori. Ethics committee approval and the author's permission, 48 adolescents between completed the memorial symptom 1 week, the first T1, the second T2, and the third T3 cycle of the memorial symptom assessment scale 1080 evaluated 30 physical, 22 tests, while of frequent tests, while were evaluated in terms of severity and stress. When a symptom was reported, 4 points were assigned on the for frequency and while 5 points were assigned for the test. You will notice that this list of symptoms includes some signs. Some signs. However, these sequelae are often unpleasant and distressing, causing deep discomfort. Causing deep discomfort to the individuals who experience.
The analysis of the assessments revealed that 56% of adolescents experiencing more than 10 symptoms simultaneously, with female patients experiencing slightly more symptoms on average. After the first cycle of chemotherapy, T1, the adolescents experienced on average of 11.7 symptoms. After the second cycle, patients reported 9.9 symptoms, and after the third cycle, 10 symptoms were reported. The number of symptoms reported range from 2 to 22. Yes. Figure 1 and 2 show the dynamic nature of symptom experiences, which demonstrates the importance of a constant symptom assessment. These graphs provide an insight on part of the data. Figure 1, we can notice that the fatigue symptoms, simplified as lack of energy, recurs constantly in the 3 assessments. While the incidence of other symptoms, such as hair loss, change in skin, increases in percentage. Conversely, the occurrence of other symptoms, such as dry mouth, pain, weight loss, decreases. Figure 2 reports a sample of the symptom experienced by individual patients. The identification number. The cases of the patients number 34 and 38 are illustrated on a dynamic. As the figure shows, where lack of hair loss, measure, feeling drowsy, while the most recurring psychological symptoms were feeling of being nervous, feeling of being irritable, of sadness. Symptoms with the highest average on a Richter scale of 1-4 find frequency, energy, and dry mouth. By severity, where mouth sores and constipation. Symptoms with the highest average on a Richter scale of 0-4 by distress, hair loss and mouth sores. Energy and diarrhea. The highest severity was reported in mouth sores and difficulty swallowing. Highest distress was reported in hair loss and diarrhea. The values of frequency, severity, and distress here listed were obtained by patients who assigned 3 or more points to their symptoms. All data demonstrates that the symptoms which occur the most are not necessarily the most frequent nor the most severe or distressful. Our study reports that adolescents with cancer experience multiple symptoms during chemotherapy. Results emphasize the dynamic nature of the symptom experience. High occurrence of symptoms does not always translate into high frequency, severity, or distress. It is therefore important to obtain a comprehensive symptom assessment in order to improve quality of life. Thank you for your attention.
Grazie Simone, mi dispiace molto per questo.
Thank you very much, Simone. Unfortunately, we had a connection problem. Now we've got a connection with the University of Limerick, Alice Coffey.
Share my screen. Am I sharing my screen?
Yes.
I just need to go to slideshow, I presume. Okay, can you see that?
Yes.
Okay.
Yes.
Okay, good afternoon. My name is Alice Coffey. I'm a professor of nursing in the University of Limerick and a member of the ProCare project. I'm presenting this afternoon on an evaluation of Project ECHO, which was a specific educational program provided in palliative care education to long-term care facilities. This project was in collaboration with colleagues in a specialist palliative care unit, Milford Care Centre in Limerick, and the All-Ireland Institute of Hospice and Palliative Care. I will just present a little background on the study, talk about the Project ECHO education programme, what it is, the study aims and objectives, the evaluation framework we used, data collection methods, and also some of our results. So in relation to background, the context is long-term care, and we know that ageing is increasing, the ageing population is increasing, and there is an expected rise in the number of people who will actually move into long-term residential care with very complex care needs. And as we know, providing care to older people in long-term care with complex needs requires particular expertise. And one of those competencies would be in palliative care. And palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses. And according to the WHO, this is by providing prevention and relief of suffering by means of identifying and assessing treatment of pain and other problems that include not only physical, but psychosocial and spiritual care. So staff in residential care settings need competencies in palliative care approaches in order to support those people who need this kind of care with life-limiting illnesses. The type of education program that I'm talking about here today is the ECHO program, which is an acronym for Extension for Community Healthcare Outcomes. This kind of program utilizes a teleconferencing platform, a methodology that was developed in the School of Medicine in New Mexico a number of years ago. And it uses teleconferencing platforms like Zoom to create a hub and spoke knowledge sharing network where communities of learning are developed. It involves collaboration between peers and specialists to address particular healthcare needs using technology and existing resources. The use of video conferencing technology, in which the use of this, participants benefit from receiving evidence-based practice guidance from specialists, and they use case-based learning approaches from presentations, along with opportunities, because it's live, to ask questions and have their questions answered. In particular, this methodology was used by the collaboration between the Health Service Executive in Ireland and the All-Ireland Institute of Hospice and Palliative Care. They provided this program in 3 different phases to nursing homes in Ireland, and it was designed to improve the staff knowledge and skills in the care and management of patients with a wide range of palliative care health needs. They provided 10 educational sessions over video conferencing from a specialist palliative care centre, which was Milford Care Centre. That was the hub of care, to participating long-term care facilities who were the spokes. And these sessions were provided over a 5-month period. The topics that were identified for this education were identified by the participants themselves before the educational program began. And topics, for example, like breathlessness management, assessing total pain, management of acute confusional states, appropriateness of artificial hydration at the end of life, managing family and family conflict, and understanding projected anger at staff, managing and advanced care planning, etc. There were some of the topics that were identified by the participants. So while this project was underway, this educational project, we were asked to evaluate the process and the impact of the project in phase 3 at Milford Care Centre. So the aim, as I said, was to evaluate the processes and the impact. So we actually conducted our study during, pre and post the educational program. So we used a particular framework to evaluate the program called the RE-AIM framework. And this is one of the most frequently applied evaluation frameworks in implementation science, devised by Glasgow in 1999. The RE-AIM framework has a number of constructs. You can see reach, effectiveness, adoption, implementation, and maintenance. And I will provide the results of our evaluation under those constructs. We collected data, as I said, pre and post the program, and the methods we used were an evaluation of the sessions themselves. We used focus group interviews with participants, and the participants of the program, not only were they the receivers of the education, but also the providers of the education. We held focus groups 1 month post the program completion. They were semi-structured interviews, audio recorded and transcribed verbatim. And each education session had an evaluation survey. We also collected data pre-education of the number of residents on the sites, the number with end-of-life care wishes documented, the number of residents who had do not resuscitation in place, number of residents who were referred to the specialist palliative care team, and the resident referral data, referral of residents to acute care or transfer of residents for other types of care. We received ethical approval from our local research ethics committee for this project. So if we look at the results under reach and effectiveness, and when we talk about reach, we're talking about how many people did this education reach. And we had 12 long-term care facilities involved in the project, with a total of 366 attendees over the 5-month period. And you can see in the sessions there, the 10 sessions, that we started with 65 but ended up with 26. And that was because a lot of the sessions were conducted during the summer period when many people were not available to attend. We also conducted focus groups, as I said, to look at at the reach and the effectiveness of the sessions, and the focus of participants perceived themselves at the end of the sessions to be more confident to deliver end-of-life discussions with residents and their families. They also welcomed the knowledge and skills refreshment through the case studies that were presented and the discussions around them. They were very complimentary of the programme. They reported an increased awareness of the residents' need and the need for a palliative care approach. The need for anticipatory medication, for example, was one of the things. So they agreed that the case study sessions would positively influence their daily practice. In relation to adoption, how effective it was and how well it was adopted in practice following the education sessions, participants' perspectives were asked on their facilitators and barriers to operationalizing a palliative care approach in practice and how the learning was implemented when it was delivered. So the facilitators identified by participants were that they had already got some clinical knowledge, and that clinical knowledge was embedded more by the education sessions and the discussion around the case studies. There was also a lot of good communication through the tele-mentoring process, and that worked very well for people, and good communication after the sessions. And they had a lot of support with resources, etc. Other barriers, however, were identified, and this often occurs in long-term care settings where there's a high level of staff turnover and a need for retraining when staff change. There was also resources provided with the program, so they kept resources and folders in their practice areas, and they shared that learning with others. There was evidence of collaboration with other multidisciplinary members of the team, and also the potential to build on mutual rapport and learning in the future. The use of technology was seen as enhancing further engagement between nurses and nursing homes and other palliative care specialists. When we compared pre and post ECHO education data, we found that there was an increase in the number of residents that had expressions of interest or expressions of end of care life wishes recorded in their case notes. We also found that there was an increase in the number of residents that were referred by staff for palliative care, and a decrease in the number of residents that were recorded as not in receipt of specialist palliative care on transfer to hospital. Post the education, 100% of the residents that were transferred had their wishes documented, which is really, really good. So we asked people then, how could this be sustained? And of course, they wanted the program to be timed correctly so that in certain periods during the year, it was quite challenging and could negatively impact on their ability to participate, especially during annual leave or holiday periods. They felt that the ongoing virtual network could be created so that this could happen more often, and that participants suggested more time could be given to prioritizing the topics before the educational period occurred. They felt that disseminating and sharing with colleagues was really excellent at the time, but there were some difficulties with live sessions because of the resources available, IT resources, particularly in the nursing homes. They felt that a project coordinator, particularly in the hub in the specialist palliative care area, was an integral part of the program. So they felt also that adding an incentive like an awarding of CPD points would help also with participation. So in relation to further research, we really need to be looking at how implementation of learning from the educational program in the clinical areas actually works in clinical practice, and to look at how the processes and the contextual factors involved actually affect the learning. Thank you for your attention. All the details about the project are on this slide. Thank you.
Grazie Alice. Ora torniamo.
Thank you very much, Alice. Now I would like to give the floor to Esther Pumarolli. She works at the Health Care Center of Alto Adige.
And thank you for this precious opportunity. Yes, I am Esther Pumarolli, and I work as a nurse in the palliative care unit of Bolzano, where I also have the opportunity to do some research activity, at more or less 12 hours per month, in collaboration also with a university professor, Professor Cavada, and a statistic, the Dr. Vitadello. And I will share with you our results of our study outlining the family caregivers' needs during end-of-life care in a hospice setting, a cross-sectional study. Just a brief introduction. Family caregiving in the context of advanced disease can be very demanding, both physically and emotionally for the caregiver, and it can also impact the health of caregivers and the palliative care team interventions are aimed, as Alice Coffey already said, both to the patient and the caregiver, in order also to prevent what is connected to the risk of pathological grief. This is why, also in collaboration with the university, we asked bachelor students to collaborate with us, and we did in 2011 a literature review to design a quantitative questionnaire to then give to the caregivers in our setting. And it's based on 3 main international questionnaires. It includes anagrammes of caregivers and patients, the duration of care provided by caregivers, the support received by our team, and also the moment of death, so the grief and the post-bereavement phase of the caregivers. We then did the final draft in 2015, and this led to the undergoing of the cross-sectional studies with the objectives to describe the profile of family caregivers in our setting, identifying what are the physical disorders and emotional reaction to the advanced disease and to taking care of the loved one, and to define how they feel supported by our team. We included in our study all family caregivers of patients who were admitted at least 24 hours in our setting and who died in our setting from January 2015 to December 2019. We collected data through our questionnaire, which is composed by 28 single or multiple choice items with a 5 with Likert scale. We just included in our study the areas regarding anagrammes, caregivers' physical and emotional disorders, and the perceived support of care. The questionnaire was sent by mail 1 month after patient death. The consent of participation was obtained during the hospice stay, and obviously it's all anonymous. We have a total of 536 responders, which consist in the 66.5% of response rate. We then can see that the majority of caregivers are women, with a mean age of 58.9 years old, and they are mainly divided in children or partners with the patients. The 30% of our responders take care for more than 1 year of the loved one. Regarding the patients, we see that they are equally divided in men and women, with a mean age of 72.7 years old. Important is to stress out that the mean hospice stays is just 12 days, so we can see how little time we have to build a therapeutic relationship with the caregivers. We then investigate what were the main physical and psychological suffering Caregivers mainly reported sleeplessness, weakness, weight loss, and physical pain. And for emotional reaction, the three main reported were worry, sadness, anxiety, and also helplessness is much reported. Most important is that 55.4% of our responders complains both disorders. Caregivers worries more about the patient's physical suffering and in taking difficult conversation with the patient about death, diagnosis, and prognosis. Moreover, 1/3 of our sample complains of feeling almost exhausted. We then stratified by gender these results, and results show that women experiences higher level of all symptoms investigated with the statistical significance of weakness, anxiety, sadness, and helplessness. Stratifying by age, we see that anxiety, worry, and sadness are highly reported by all caregivers in all ages, and that irritability and anger and helplessness, is invertedly proportional to age. We also stratified by relationship with the patient, and the results show that spousal relationship have higher levels of worry. So our results confirm what also the literature say, that women are the predominant providers of informal care, and that they are also the profile more at risk, also with the younger caregivers who show more emotional fragility. The results confirm also the emotional triad of sleeplessness, weakness, and worry, which is also related to a higher risk of developing depression, burnout, and therefore also pathological grief. We then conclude that it is important and necessary to develop effective assessment instrument for the family. Literature suggests that the narrative interview or the Calgary Care Model, a family member agenda, or the cognitive assessment with the ABCDE technique. It's also interesting to reflect about the ratio number of nursing per patient, including also the family members. Finally, further research is needed for post-bereavement phase, and also to study how the COVID-19 pandemic affected caregivers in a hospice setting. Thank you for your attention.
Grazie Esther per essere stata qui.
Thank you very much, Esther, for being here with us. Now we have other 3 presentations from people connected remotely. So Angela Tolotti, she works at the Oncology Institute of Bellinzona in Switzerland. Welcome.
Non ci senti? Non ti sentiamo, Angela?
We cannot hear you, Angela. Maybe you need to turn your microphone on. I think the audio is not on. Your microphone is not on. We cannot hear you. Can you hear me now? Yes, we can. Yes, we can.
Sentiamo.
Ok, bene. Grazie, scusate.
Thank you very much for giving me the opportunity to share the results of this experience, of this research that was made together with the university and the hospital I work with. And the purpose was to investigate and improve the nursing role in the interprofessional palliative care team. This is an ethnographic study. We know that the oncology nurses have a key role in the palliative care provision, and that the research highlight that the role of the advanced practice nurse is very important, since it is widely reported in the literature that it is still underdeveloped in the Ticino area in Switzerland. And in particular in the palliative sector. So starting from these conditions, we decided to explore the current nursing role within the interprofessional team with a view to developing the APN role in palliative care. So as the previous speakers said, it is important that researches are made in a very rigorous way, and they need to respond to the organizational and clinical needs. As it is reported in our literature, the collaboration between faculty members and nurse researchers can support students in planning their research projects. So we carried out this research together with a student from our university. The objectives are the following. So to describe the current role of the nurse in the palliative care within the interprofessional team, then to identify the main approaches to interprofessional collaboration, and then to highlight strengths and weaknesses within the current nursing role in order to analyze the possibility of enhancing existing competencies to develop the APN role in palliative care. So we said before that this is an ethnographic study. We used certain methods to collect data. We have participant observations with interprofessional visits to patients' bedside and interprofessional meetings that are video recorded. We interviewed both expert and novice nurses, and these interviews were recorded. Then we carried out data analysis, and we used the NVivo software. These are the main results. We collected data in the first semester of 2020. We managed to carry out the research, and the setting was the palliative care inpatient unit in Bellinzona. We had 3 interprofessional meetings, and then 3 interprofessional visits to patients' bedside. As to the interprofessional meetings, we analyzed the styles of meeting management, and we had 2 people carrying out these interviews, so the manager and the nurse. We observed the interaction between the nurse and other professionals, including spiritual workers or social workers. So it was the nurse who could influence the others. And then, as to the interprofessional visits, we observed that the patient felt a bit scared because there were lots of professionals and sometimes the communication was not very good. Here you can see the results of the interviews. We had 5 interviews with expert and novice nurses. They are mainly women with an age between 29 and 48 years. And the nursing experience is from 2 to 21 years. And the palliative care experience is from 2 to 12 years. And then there were 3 of them who had an advanced education in palliative care. As to the interprofessional collaboration, we defined the role of novice nurses and expert nurses. And not only they exchanged information, but they gave a specific contribution that gave another value to the team. As to the second type of meeting, we noticed that the role of nurses was essential because the nurses make sure that the goals reached are those that were set together with the patient. Then there is a third topic. So there is a role of advocacy and point of reference. Nurses also have the possibility to improve their skills and competencies. And as to their potential nursing role developments, we can see that there are developments in interprofessional collaboration. Nurses can reach their goals, and then they see that their role can develop. So just to conclude, we can say that the research highlighted the fact that the nursing presence within the interprofessional team is evident. Nurses described the need for further education to develop advanced skills, and we believe that faculties have a key role in the development of educational programs to address these needs. And we also noted that the collaboration between nursing staff and university faculty can develop research studies to reduce the gap between theory and practice. Because researches start from the problems that occur inside the hospital, and then they can lead to an improvement in our clinical practice. And in the future, we are going to develop the role of the APN in the local setting. Thank you very much for your kind attention.
Grazie Angela per il tuo contributo.
Thank you so much, Angela, for your contribution. We have now concluded with the presentations from our colleagues with speeches in the clinical domain. Now we will connect remotely with the University of Turin for phasing training for nurses. Let me introduce you Johnny Acquaro. I see you are already there, connected. Good morning. Can you hear me? Yes, we can. Perfect. Good afternoon, everybody. Thank you so much for giving us the chance to present, and share with you our study about nursing students' clinical experiences. COVID-19 pandemic has determined some significant changes all over the world in several terms. As for the healthcare system, the impact was huge. Healthcare services were under pressure, and healthcare professionals had to face challenges in ethical, organizational, and healthcare systems. The pandemic emergency had also an impact in terms of training for professionals of healthcare. The degrees in nursing had to change completely. The lessons moved from face-to-face teaching to distance learning, and internship activities were suspended. The university wondered about the consequences and opportunities given by the pandemic, about the teaching and clinical practice and involvement of students. As for the local experience, our experience, the degree in nursing in the city of Turin has also changed modality of having lessons, moving from face-to-face lessons to remote lessons. In the moment of opening of activities on the ground, some students from the third year were put in structures and COVID-19 services organized on the territory in order to face the emergency. The experience of students in clinical practice during the pandemic is not a well-explored domain today. So exploring these experiences is the objective of our research. The experience of students were used through a qualitative research approach. The research was carried out at the nursing degree department using some volunteer third-year students who were the participants in the purposive sampling. The method was used on the whole territory. The first group experienced the study in April-May 2020, the second group in December-January 2021. What about the instruments of data collection used in our research? We used the instrument of focus groups online during the first wave of the pandemic, and narrative diaries as well. As for focus groups, one of the main questions was about describing personal experiences. As for narrative diaries, we require them to describe experiences and possible future situations. These students expressed their consent to the use of data, and the interviews and data were used in an anonymous mode for a specific code. We used the approach of content analysis in terms of data analysis, and the methodology was used through focus groups and diaries used by 2 researchers, and one of them was not immediately directly involved in data collection. What about the results? The results were then shared with all the participants involved. The students who participated in the study were 49 men, 4 women. The mean age is 23 years. The analysis of data allowed to identify the flow and categories, and we highlighted 10 categories through the identification of 3 main themes: the factors affecting which have influenced crossed and characterized the experience, factors affecting professional identity, and finally characteristics of the organization. The first subject describes the various factors shown during the various experiences. So fear, specific characteristics of the new scenario, and so on and so forth. In the second group, we have the various categories which influence the professional identity. We have collaboration with the working staff, the use of reference professional modes, and the use of the experience from the professional point of view. The third subject describes limits, weaknesses, and strengths of the organization met during the various paths, such as the availability of resources during the pandemic phase and the organization of the different works. The experience described by students is similar to what we have in the literature reported by students and professionals, both linked to the COVID experience, but also before the pandemic, with some specific studies. Specifically, the availability, the active participation aspects such as fear for being infected by the virus. This was also true in the past for previous flus, such as swine flus. Then this was referred to the second wave of the pandemic, specifically including anxiety coming after that. Then ability to develop strategies of coping and adaptation, acknowledging learning opportunities, coping strategies, and the sense of professional belonging. To conclude, the data emerged from this study mainly reflect the experience of students who participated and cannot be used in general terms. However, they allow us to understand the experience of the clinical, pandemic clinical experience in line with the purposes normally used for professional healthcare degrees, namely development of professional skills, professional identity and belonging, and socialization to work. We have, however, to consider that emotions were there, so responsibility, risk, safety, fear, uncertainty. This is why nursing degrees must wonder about the involvement of students in this particular situation, assessing the exposure to risks, the responsibility, so envisaging for constant supervision, looking for the well-being of students and their ability to cope with the stressful situations. Thank you so much for your attention. Thank you so much, Johnny. I think we are on time. We can have Liz Kingston again from University of Limerick. Welcome back.
Am I sharing my screen now? Not really.
Ho letto.
Hai detto bene.
No, ma è comodissimo, è molto meglio che dal vivo perché
Can
qui
you
avevo le
see
slide.
Can you see
C'è
the presentation?
un'interferenza, scusa.
Yes, yes, we do.
Okay, shall I start?
Yes, please.
Okay, thank you. So my name is Liz Kingston, and I'm a member of this research team and also a member of the ProCare group. So thank you for the opportunity to present today, and congratulations to everybody involved in the success of the conference so far. It's very enjoyable. So I'm presenting today on a research study conducted in relation to fourth-year nursing students' perceptions of their educational preparation in medication management. So the outline of my presentation is I will talk about the background, the rationale, the methods, the findings, and the discussion. So why is it important to look at undergraduate nursing students' perceptions? Well, we know that medication safety is an integral aspect of patient safety, and there are inherent links between undergraduate nursing students' preparation in medication management and linking that to patient safety. Nurses, as advocates of patient safety, actively consider medication safety in the course of their daily work. And so it was important to consider the educational preparation of nursing students as they will be the future caregivers as registered nurses. So the aim of our study was to explore nursing students' perceptions of their educational preparation in medication management across the 4 years of their undergraduate nursing degree program. Ethical approval was from the University of Limerick Research Ethics Committee, and the design was underpinned by interpretive phenomenological design. Our sample was final year or fourth year nursing students of 3 undergraduate nursing programs: Bachelor of Science General Nursing, Bachelor of Science Intellectual Disability Nursing, and Bachelor of Science Mental Health Nursing. Our study involved 14 semi-structured face-to-face interviews with students on a one-to-one basis, and data was analysed using content analysis. And the voices and the interpretations of the participants were fundamental to understanding the nursing students' perceptions. So from our analysis, 4 themes emerged with a number of sub-themes. The themes identified were developing an understanding of medication management, embedding this knowledge in practice, engaging in practice, and accepting professional responsibility. I'll now talk about each of these themes in detail. So when we looked at developing an understanding, we had a sub-theme in relation to the meaning of medication management. So we found that students had a narrow focus. They interpreted medication management as meaning oral medication to the exclusion of other types of medication management, for example, intramuscular, subcutaneous, and so on. So they limited and focused on oral medication management in this study, even though we did not ask them to. And this perception was driven by their clinical experience. Wider issues in relation to medication management included the changing role of the nurse, so the dynamic role, and the nurse within the multidisciplinary team. And patient education and patient safety was of interest and concern to students. There was a fear of making mistakes that could endanger patients. So for example, one participant said, "You're really nervous, you know, because these are big mistakes. These are important things. People can die. You are now legally responsible for it, so it's very scary." Our second theme was embedding knowledge in practice. And under this, we looked at pharmacology module. And students reported that this module was essential in developing a strong knowledge base. They really valued the clinical skills laboratories as a safe learning environment that enabled bridging the knowledge practice gap. So one student said, "It's a good way to learn because for people in a big lecture hall with 200 or 300 other students, and you're just kind of going, oh my God, I'm like a lost sheep in here. But in the labs, you're more inclined to get involved because it is so small, so informal, and you're in a comfort zone." In relation to clinical placement, students valued the real world setting. One student said, "There's only so much you can learn here in class. I think it's just doing it in the hospital that you get used to it and it all comes together." In relation to technology enhanced information sources, this was an interesting finding because students reported a covert use of phones and apps, and there was uncertainty among students as to whether this was allowed or not. However, they were mimicking or copying the behavior of registered staff also. So one student said, "I know you're not supposed to have phones on the ward either. Sometimes it comes in handy. You would see some of the nurses and doctors taking out their phones and going to the apps." So this was in relation to enhancing their information and knowledge around medication management. The third theme was engaging in practice. And here we found preceptorship and support. So there was a culture of positive preceptorship in clinical practice, and this was very conducive to learning. And this was usually instigated and led by the nurse in charge of the unit. The clinical nurse manager, she was really involved about making sure we had the same preceptor and just people who are willing to teach. Multiple sources of support were also mentioned, including the multidisciplinary team members, the nurses, the managers, the patients, and indeed the peers. One student said you'd learn a lot from the patients too. There were missed learning opportunities, and students reported this due to the very busy working environment. It's up to us to be like, "Oh, I do the drug round," and you could be in the middle of that drug round and a bell will go off. And it's the student that they're going to send off to answer the bell. And then you're gone and the drug round is over and you've missed everything. Our fourth theme was accepting professional responsibility. And here the sub-themes were personal responsibility for learning and perceptions of a future medicines management role. So in relation to theme one, or sub-theme one, personal responsibility for learning, there was certainly an awareness among students of their own responsibility to learn. There were positive regarding responsibility and motivation and initiative. They regularly engaged in self-directed learning to address their knowledge gaps, and they were beginning to take responsibility for their own learning. And they had perceptions of a future role in medication management. They had mixed emotions, however, from being excited to fearful, to unsure of expectations. They had self-doubt and they were comparing themselves to their peers. All your classmates have done stuff and you're like, "Oh my God, they've done that and I haven't done that. I must be terrible." It's something as a final year student, you want to be able to do things on the ward, to be part of the team, being able to do the drug round and to do it right and to be confident about it. You're not in first year anymore. Things are expected of us now. So what does this all mean? Well, we found that participants were developing their knowledge about medication management and were attempting to embed that knowledge through engagement and full immersion in real life clinical practice, while at the same time acknowledging that taking professional responsibility for their own learning trajectory as nursing students. And our findings were based on interpretation of the participants' voices. The findings point towards the need for a collaborative developmental approach to medication management education across the university and the clinical placement settings. A pedagogical approach that focuses on integration of theory and practice using, for example, simulation, technology, and a spiral curriculum approach across the 4 years of students' undergraduate education is recommended. And finally, the ultimate goal is to ensure that the gap between academia and practice is bridged, and upon graduation, students will feel adequately prepared for practice and possess the requisite knowledge, skills, and behaviours to practice safely, effectively, and competently. So thank you very much for listening today. These are my contact details. I'd be happy to speak to any of you if you would like to learn more about this study. And the study is published in the journal, which is Nurse Education Today. And I have included a link here. This is a peer-reviewed quartile 1 journal. So thank you very much for your time.
Grazie Liz.
Thank you so much, Liz. Now we have the last presentation here with Sara Marcori from the University of Trieste, Università degli Studi di Trieste. Good morning, everyone. I am Marcone Sara. I work in the ER department of Trieste. This is a study carried out for my degree in November about the out-of-hospital cardiac arrest, the knowledge of students of the University of Trieste. First of all, let's take a look at cardiac arrest, which is a sudden loss of the mechanical activity of the heart, which is associated with loss of breathing and consciousness occurring outside of a hospital setting. It is not a rare event. In fact, we have more than 275,000 deaths in Europe. 70% of cardiac arrests are witnessed, but the survival rate is only up to 10%. This because most of the witnesses cannot cannot intervene immediately. What about the causes of cardiac arrest? We have primary causes such as ischemic heart disease or non-cardiac causes such as hypoxia. Then we have the treatment, the so-called chain of survival, where everyone should know and how to do CPR. So first of all, we have to activate a system of emergency, then start with the CPR and equip ourselves with the necessary devices waiting for emergencies. This must be well known from the overall population to try and increase the survival of these patients. What about the objective of our study, assessing the knowledge of the University of Trieste students on resuscitation maneuvers and the use of AED through a qualitative transversal perspective observational study? We carried out a study with 25 multiple questions. We work with 21 faculties of the university, 10 in the health sectors and 11 in the non-health sector, with a total amount of students of 1,686, mainly women. Female students. Therefore, what about the results? First of all, we investigated the number of students who knew something about the right position of hands during the survival maneuver. In this case, 33% of students responded, gave the right answer, and sometimes there were no differences in the categories involved. Then we identify the frequency of chest compressions and the knowledge about chest compressions. Also, in this case, only 36% of students gave the right answer. Then we consider the number of students who knew something about the depth of compression, which has to be about 5 to up to 6 centimeters. Then we wondered about the students who feel sure of how to do CPR or not sure on how to do that. And the result is that only 12% who said that they were quite sure were capable of answering and placing hands during CPR. Then we spread knowledge of those who already had BLSD certification, and they could reply about questions about how to put hands, the depth, and the right relationships. Then we analyzed knowledge about AED. So what is the closest AED to the classroom? 60% said, I know where is the closest AED in the classrooms and how to use it. The percentage is very low of people who know how to use it. Then we consider the number of students who knew something about the sequence chain of survival, the right sequence chain. The results in this case were quite good. In fact, 86% of students were able to know that. And then we had positive data about the availability of people involved to join a BLSD course. In fact, 91% of them said they would like to join this type of course. And they say that this should be mandatory in school learning activities. And this is mandatory in countries such as France or the US, where this culture is quite widespread at school, where we know that the percentage of victims is sometimes very high. What about the limitations of our study? Well, first of all, it was an anonymous online survey, so probably students found answers online, and probably we overestimated their knowledge. Second, our sample did not consider all the faculties of the university, but only the University of Trieste. So probably our results are not the results of the whole territory, Italian territory. To conclude, most students would not know how to practice hard message properly. 9 out of 10 students do not know where is the closest AED to their classroom and would not know how to use it. To conclude, we can say that the first step to increase the survival of out-of-hospital cardiac arrest victims is related to the knowledge of resuscitation maneuvers, not only of health professionals, but also of the rest of the population, who may save so many lives. Thank you so much for your attention.
Grazie Sara, ora ci colleghiamo di nuovo.
Thank you so much, Sara. Now we have the Autonomous University of Barcelona with our colleague, Juan Manuel. Welcome.
Hello.
Sì?
Hola, okay. So hello everyone, and thank you for having me today here. I'm going to share with you the results of teaching experience we are implementing in my university, and it's called narrative photography. It's a mixture of using photo voice and reflective thinking, and I'm going to share with you 4 different experiences we've conducted here. Okay, can you move to the next slide, please? Okay, thank you. Next one. Okay, as you all may know, when we are talking about competencies, we are talking about improving our knowledge, our skills, and our attitudes. And I'm sure you are all familiar you're all familiar in teaching about knowledge and skills, but attitude sometimes is left behind, or we are not investing so much time in teaching attitudes. So next slide, please. So there are some experiences in the literature that they use art-based methods to improve these attitudes. Okay, fine. Okay. Okay, thank you. Thank you, DeMarco. Okay, so there are some evidences in the literature that they're saying that we can use art-based methods. There are plenty of methods, such as body mapping, or using pictures or drawings or puppets, to improve these attitudes when we're talking about nursing care. But very few of them are mixing together art-based methods and reflection. And this is why we decided to use together photo voice and reflection, and we called it narrative photography. So the aim of this presentation, we are gonna, I'm gonna share with you the satisfaction and the effectiveness of narrative photography in nursing students, and also to reflect on its possible application in care settings. So I'm gonna share with you the descriptive analysis of four experiences using narrative photography at Universitat Autònoma de Barcelona. Universitat Autònoma de Barcelona is one of the two public universities in Barcelona city where nursing studies are taught. So these four experiences were focused, two of them the topic was teaching about empathy and HIV and caring for people living with HIV. Another experience was about teaching gender perspective in nursing studies. Another experience was about dealing with antiretroviral therapy, and this one was conducted with a patient. And what we did was to assess satisfaction using an ad hoc instrument, and also we used the interpersonal reactivity index to measure the empathetic attitudes. And also we had some open questions where students or participants were able to share their thoughts and also some experiences. So in terms of quantitative data, our post-intervention analysis showed that women had higher scores in their overall interactivity reactive index, and also in the dimension of fantasy and empathetic concern, and also in personal distress. All the three of them with significant statistical significance. Also, a significant association was found between the interpersonal reactivity index and also the perspective taking dimension, and also choosing nursing as the first option. And not having healthcare experience was also significantly associated with the empathetic concern. And as you can see here, more than 80% of the participants said that narrative photography helped them to cultivate reflective thinking and also to realize how people living with HIV may feel. And also almost 90% of the participants said that narrative photography helped them to eliminate some of their prejudices about HIV and AIDS, and also to contemplate different points of view, as well as recognizing the importance of providing humanized care, and also to identify discriminatory behaviors when caring for people living with HIV. And around 70% of the participants indicated that narrative photography taught them more than traditional lectures. As an examples of the pictures of the materials that the students prepared in class, this picture here represents feeling professional care, and the student said, the text you can read here, we often associate a hand as a symbol of help. Touching allows patients to know that nurses are there to help them, that they will always have their hand to hold on to. People with HIV have experienced very different situations with healthcare staff. Some have been in favor of making a positive change in the outlook for the diagnosis, but there are other people who have had to go through very unpleasant situations, in which case this hand has become a barrier, most likely caused by ignorance and prejudice that still exists. As you can see here, the students are able to identify how people living with HIV are experimenting stigma and discrimination. This other picture you can see here is actually a very creative picture. The student bought a heart, a real heart from a cow or from a pig, and she put it into her mouth and took this picture. And she said this text: to receive the news that you've been infected by HIV must not be nice. This picture represents what this would mean, literally, to lose your heart through your mouth. The most important thing in your life is gone. The heart moves everything, your feelings, your life, etc. And the change, the golden change here, she said that it was representing living tight, living always thinking about your antiretroviral therapy. And also here, this is the picture that the patient made. We were talking with him about managing his medication, and he said, I can't live with or without you. That was the title of the picture. And he said, a rose, a symbol of love, beauty, and perfection, is here surrounded by lots of Persista, which is the name of the pill. This conveys a duality in meaning of the restrictions and agony of being forced to take the Persista, but also the warmth and fostering of protection derived from the pill, pills against the illness. I must embrace the constricting presence of the pills in order to blossom into the full, healthy life I desire to live. So as conclusion, we can say that the use of new art-based methods such as narrative photography and also reflective thinking improves nursing students' empathy compared with traditional methods, and also that nursing students are very satisfied with narrative photography as a teaching method. I can say that also the teachers were very satisfied. The sessions were always very fulfilling. And of course, more research is needed to demonstrate its efficacy in different scenarios beyond HIV. I have to say now that we have completed a randomized controlled trial in the physical therapy degree, and it has shown very good results, but I cannot share the results yet. So I hope to share with you in a very near future. So here you have my contact details and some references. If you have any questions, please don't hesitate to drop me an email, and I'll be very happy to answer you. Thank you very much.
Grazie Manuel, presento l'ultimo.
Thank you very much, Manuel. We also have a speech by Marietta Logar-Čuček, from the University of Ljubljana in Slovenia.
Can you see my presentation?
Yes.
Sorry, yes. Okay.
Please go in presentation mode.
Sorry, can you see it?
Okay, perfect.
Okay. Thank you very much. Thank you. Thank you all for being able to participate in such an important event. I will present an article with a title, Integrating Leadership Skills into Healthcare Education. Research on the findings and approaches to improving the leadership skills of nursing staff has highlighted the need to gradually develop leadership skills. Nursing staff should acquire the foundations of these skills during their studies through additional training and the acquisition of competencies necessary for healthcare managers. The review of scientific and professional literature, which included published works from 2017 to 2020 in the COBIS, Google Scholar, PubMed, and CINAHL databases, was conducted using the following phrases: culture and leadership skills, leadership training, and the future of leadership. Altogether, 2011 sources have been reviewed, out of which 70 freely available sources have been included in the final selection. The so-called qualitative content analysis principle has been used to source analysis, the central process of analysis being open coding. Leading people is an art and requires more than just thoughtless following of rules. Good healthcare organization management requires applicable action, timely decision-making, and changes for the benefit of patients. Patients expect and deserve timely and quality treatment equally accessible to all. Leadership in healthcare is expressed through individuals who know themselves and subtle behavioral response styles in different situations, successfully manage, share their power, have a vision based on experience and good practice, anticipate change before others. Effective leaders are those who possess the following characteristics: excellence in communication, empathy for employees and patients, ability to adapt to change, and learning agility. Learning must be fast and efficient. Also in healthcare, a lot of attention is paid to sustainable leadership by inspiring example that allows the realization of one's own ideas and initiatives, requires care for nature conversation, includes the needs of future generations. Preparation to promote excellence in leadership and successful change management in healthcare should begin as early as during the education period. Healthcare faculties play a key role in the development of leaders in healthcare. They must act as change agents follow new learning strategies, and use the latest learning technologies. Training for leaders must take place both in the academic fields and in the clinical environment. Leaders need to be groomed. The vast knowledge and many examples of good practice obtained during the learning process will enable students to respond positively and successfully in practice as future leaders in healthcare. There are several reasons for the need for leadership skills training. Ability to anticipate change, ability to quickly adopt and understand people's responses, culture, and find appropriate solutions, clearly set objectives, ability to cooperate, tolerance to ambiguity. The functioning of healthcare as a professional field and science. What is more, leadership is not just a matter of management staff. Employees must make decisions every day, transfer responsibilities during shift changes, be role models, and influence co-workers. Last but not least, the need to strong and effective leaders in education, research, and clinical practice has greatly increased. Weaknesses of the education process at healthcare faculties. Faculties must first take care of leadership training themselves. Insufficient time and space in educational programs is developed to the acquisition of knowledge about leadership skills at healthcare faculties, or it's not part of their programs at all. Students or employees acquire leadership skills at other faculties, Faculty of Economics, Business, or managerial colleagues. Students and employees are too often forced to rely on the transfer of leadership experience from individual lectures. The responsibility for including the development of leadership skills in the curriculum has become a matter for individual faculty members. Topics related to leadership in healthcare should be included in the list of set titles for final thesis, diploma and master's thesis, doctoral dissertations. Let us conclude with the following findings. Leadership training represents success both for the faculty and the clinical environment. In the clinical environment, the search for appropriate forms of leadership is transferred to individuals. Without a basic building block, the necessary knowledge of leadership, leaders and employees in a team or at the level of an entire organization face constant challenges. Improving the quality of healthcare is more difficult to achieve without a leader with wide knowledge and leadership skills. Leadership does not mean taking over the models of already established leadership practice and tools. On the contrary, it's necessary to co-create and live them. Healthcare staff and patients need to be given hope and safety, and this is the job of leaders. So we are building the future and we are not waiting it to come. Thank you very much.
Grazie Marietta.
Thank
Devo
you very
dire
much.
che abbiamo
Thank you very much, Marietta. We concentrated lots of different contributions in a very short time, so I think it is quite challenging to follow all of these different speeches with different focuses, different approaches, different methods, both in terms of quantitative data and qualitative data. Together with our colleagues from Maribor, we have already collected all the abstracts, and we will include the abstracts and the posters in our folder. We are 10 minutes in advance now in the agenda, so if you want, we can start a Q&A session. I must say that I am very pleased that we shared all of these works. In the past few weeks, I've been in touch with my colleagues via email or over the phone, and meeting here or seeing you face to face or remotely is really very beautiful. I would like to thank all of you. do you have any suggestions or any remarks about the presentations that we saw today in the afternoon? Well, I must say that this last speech was connected to the first speech that we heard in the afternoon. So we stressed the importance of the workplace, the nurse leadership, and the competencies that we have heard today. So I'm talking about the collaboration between professionals, and I'm talking about nurses or professionals coming from other sectors, and the involvement of the nurse at all levels. So we touched lots of different topics. So the competencies, the professional development, the different approaches to treatment. And as Lucia was saying before, we saw lots of different types of research, so from observations to quantitative studies, qualitative studies. We had lots of researches. We tackled lots of different topics. And the vast majority of the research projects are based on the issues and the problems faced by nurses in their clinical practice on a daily basis. So again, it is the nurses who work on a daily basis with patients, so they know exactly what are the fields that we need to investigate. This is very important, because in this case we can give the best answer to our patients. Do you have any suggestions or maybe questions about the speeches? Silence. Are you happy? Are you super happy? Well, good. I'm pleased about that. Now I would like to give the floor to my colleagues who will start the round table.
Okay. Are you ready to do some more? Yeah? The last thing that we are going to do now is the closure of yesterday and today, the closure of all the themes that we have touched. This will be now a discussion about the ProCare project, how to present some further eventual developments in nursing research, how to see the university and hospital cooperation, and which perhaps maybe you and we have some recommendations that has been seen during the project and during this presentation. So, Maura, if it is okay with you, I warmly welcome you, first of all. We met yesterday. So, I welcome Maura Mesaglio, Azienda Sanitaria Universitaria Friuli Centrale. Very well. Again, thank you. Maura, if you agree, I would give the floor to you. Thank you.
Grazie.
I am very honored to be here today because research is not my daily work. I am in charge of management, but as you have highlighted, those who are in charge of management and the hospital managers and the work organization managers must be deeply committed and understand that research is fundamental for the employees that they have. I have my own idea, which is based on my experience and my work. I work with 3,479 workers, 1,500 caregivers who work with nurses, and 153 midwives in a company, the Azienda Sanitaria Universitaria Friuli Centrale, where there are 9,000 employees. This is just to say that we are in a very complex situation because we've got a very large company. We are highly specialized under a clinical point of view. And this explains why we should have a special attitude to research. But besides this reflection, why do we need to develop a research? What are the facilities that should be in charge of these issues? What are the limits and what are the opportunities? Because those who spoke before me also spoke about sustainability. This is a fundamental key aspect. How can we do a research in a context in which there is a huge clinical commitment and resources need to be re-enhanced? I'm not saying that we are running out of resources. I have written throughout the day, so I need to summarize everything in a nutshell. So some of the matters concern some concepts that are well known. Hospitals, universities are fundamental for the research sector. This is not a main concept for our work, because normally we just work in the clinical sector, but there is an original mandate which is specified in the regulations of the universities. We are an academic hospital. There are other academic hospitals in our region, and our university is certified by means of certifications of quality. So we've got we are certified by AMBUR, which is the association that certifies universities. So this is an institutional mandate. The regional governments have some corporate deeds, and in these deeds there has to be an institutional mandate of research, which is not something that is mandated to universities, but it is mandated to the organization. So there has to be a combination of collaboration between the hospital and the university as far as research is concerned. We have protocols of understanding that are basically documents allowing to provide education for students during internships. This is a partnership that we already have with the universities. But this needs to be structured, and nowadays we don't have this structure, so that we can express our main goals. We can include the resources dedicated to research, because nurses must be supported in developing the research questions. What is important is the work of nurses. The nurses have an attitude towards research. They investigate what is going on among patients. So as we heard today, we don't just look at the here and now, but we have to look at the future of our patients. This is something typical of the way of working of nurses. Nurses want to carry out researches, but the workload is too much, you know? Now, I would like to talk about the workload. And those who know me already know what I'm going to say. We need to reassess, we need to change the way nurses work. Sometimes they have too many tasks. And I'm not making reference to the administrative tasks, but to the organizational tasks. During the pandemic, we saw that nurses have to deal with the organization rather than clinical aspects. So materials, technologies, putting devices at the disposal of their patients. So we need to take organizational tasks away from nurses so that they do not waste the time. Research also means choosing. And this is something that should be considered by the management as well. Because when we are recruiting new people, we want to understand their clinical attitudes, but maybe we're not interested in their research attitudes. This doesn't lead to a disadvantage to the organization, because the nurse is included in a specific clinical job, but then in the long term they do not deal with research. So I decided to divide suggestions in this way. So let's start from competencies and skills. This is an aspect that applies to nurses interested in research, but it also applies to the role of tutoring. You know, nurses don't have lots of time and they cannot do everything. We need to develop structures and facilities supporting those who are interested in doing research. We need coordinators who can support and select the research matters. We need to put at the disposal of the nurses some structures so that the redundant matters, so that we can understand whether there are any redundant matters. We need to make use of the nurses' ideas to understand what are the difficult questions, or those that are not evident in the daily practice, or those that bring to risks for patients. to patients. So an adverse event could lead to a critical situation or the death of the patient. And nurses need to make us understand what are these problems, not the redundant problems. It would be useful to create some situations that filter the ideas of the nurses. So we should build up a database made on the nurses' ideas so that we do not further investigate in redundant things and we can focus our research in more fruitful sectors. In terms of technology, when we talk about technology, we need to be very careful because putting at people's disposal many data doesn't mean that nurses can fully understand how to use them. So maybe in the past we had no data, now we have millions of data. We put them into a system and we believe that everybody can interpret them. But it's not that we can understand all the topics. We need to have IT systems with filters, filtering data, the data that we need. And then we need to have analysts. In a hospital like ours, where there are 8,000 people, I can't hope that a nurse analyzes data, but we need to have analysts. We need to ask the right questions, collect data. We are at the bedside of patients, but then it is the analysts who have to analyze data. We as managers have to create a structure around our employees who want to do research. And then there is another work that we should do. We should observe how nurses do research, how their attitude changes towards the patients. We're not doing it at the moment. We just want nurses to do research, to investigate, and to get data, but then we do not observe them. These are new competencies and new skills that the management needs to have. And in terms of organization, if we want to give more time to nurses and build up time banks for research, we need to free nurses from those activities that they do not have to deal with. So we could make use of other professionals. Sometimes we replace clinicians as well. So we need to reflect on the administrative aspects, on the redundancy aspects. Then we do things again and again. We should analyze the organizations, remove redundancies, have a lean approach, because nurses keep on coming and going. They walk for miles inside their wards, and we could avoid certain things. So we should focus much more on time. We should create an environment that fosters research. So we need to assign responsibilities. We need to ask nurses to do research, because if we expect that researchers on their own do research, then we are wrong, because sometimes they have to work in very difficult environments with different organizational systems. So we need to give nurses responsibilities and give them time to do research. This is the management's work. Because as we heard today, sometimes we do not involve nurses in research properly. And in our regions, I mean, we work based on the policies set by the regional governments and the different organizations dealing with healthcare or the stakeholders need to contaminate the policies of our regional governments with matters concerning research. Because if it is true that my work organization depends on the regional government's mandates, then in these mandates we need to specify that we need to do research. So it is necessary to have a single vision of this need, because this is a problem that starts from the bottom, from the regional policies. It passes through the management of the universities and the organizations, and it reaches those who have to accomplish this task. So this is the synthesis of what we said today.
Okay, I didn't know that we said that many things. I mean, so much important things. Thank you. What I see is from everything that we have talked today, from everything that you have said now, is, of course, the still continuing urgent need to arrange, to put things in order at multiple levels. Yeah, so starting, this is the key, in my opinion, our opinion, from the, let's say, the project group and the one who are here today. To synthesize at many levels, starting, of course, at the bottom. First, you are the first line. You are the one who need to have this wish to start researching. You are the first who need to have the wish that you want to do the research. And then it goes from bottom to the top. And with the help of the project like ProCare, this is like a one little piece in the bigger picture. This is how then the improvement is made. And the louder you are, the louder we are, the better chances we have to reach the policy at various levels, national, international, etc. Anyone else? Yeah, Alisa, thank you.
Sì, non so se I colleghi vogliono prima interagire.
Maybe our colleagues want to say something about these few words. Let me give you some reflections and some recommendations about the future. Katja is urging us to think about the future of this project and its branches. First of all, let me thank Maura Mesaglio, because being here with us today, she showed the commitment and interest coming from the leadership towards the projects of our companies from Bosen, but also from outside of our boundaries. What about the take-home messages for the role that I am playing? Well, first of all, let me say something about one reflection of Maura. Companies have a different mandate, different from healthcare, and a university has a different mandate, which is teaching and research. Universities are wondering in the last times because only doing teaching is useless. So all over the world, we are wondering about having teaching universities only, or maybe if teaching is better when accompanied by research. And at the same time, we have a response coming from the literature, which is very clear. Students learn better and are better professionals if they grow in a context where we teach very well, but those who teach do a lot of research. And we cannot tell the same for companies. Well, patients are well managed and better managed. In that context, there's also research, because basically research starts with solving problems for patients. Our approach is a continuous approach towards research. When there's a symptom, where there's a problem, an issue with a patient, diabetic food, for example. So this is the clinical approach that we have to use, that we see constantly in our practice. This is a research approach that we have to have. So the first point is about healthcare and university companies. Without necessarily having universities, well, can they live without research? No, absolutely no. They have to make use of research and do research. Second reflection, when thinking about the first speeches in the morning, we think about the environments generating research, but also well-being, but also appeal, will to grow and develop ourselves. And there's a keyword, and this keyword is becoming a meta-reflection, is transversal, is cross-sectional. The environment is important when we talk about research, when we talk about research, when we talk about better results for patients. So this is a cross-sectional concept that we have to take into account. And then your comment about the gap between applied knowledge and learned knowledge is fundamental. It is astonishing to me to learn about these research experiments, because we teach poor research in universities. I mean, these competencies, these skills are much more when compared with what we actually teach. So we are worried about nurses, but also doctors and other operators. We do not know whether we are underusing or overusing these tools. Third reflection concerns barriers. The look about barriers, well, I'm curious about these aspects. Our colleagues presented the barriers, but they're also facilitating factors. Normally, we see the glass as an empty, half-empty glass, but actually, we maybe did something good. We had the capacity of intercepting problems, solving problems at all levels. So maybe here we have to study the facilitating aspects rather than the aspects which are actually obstacles or barriers. This could be an interesting perspective. And then a couple of take-home messages. We often discussed about research capacities today, and we can say that we have several layers, several levels of capacities and research capacities. We started with journal clubs this morning, having the ability to translate these to do applied research, so to apply what was discovered by others. Then we have heard about problems. We've heard about examples where we identified gaps. Our colleague has introduced the gaps, the rooms for improvements. Then we've heard about examples of research, such as the colleague from Turin, who expanded methods, and some other expanded knowledge instead. So we have to stay within these balance. So probably the level which is closer to patients and companies is different from a level which needs sophisticated methods, which is maybe closer to the academic world. However, those two levels have to go hand in hand. Last reflection, I share that with Maura, that we need a strategic plan. I mean, these spontaneity, these free research, well, that's fine. We are celebrating that today. We know that we have several forms, several shapes. It is quite various. We have it in Ireland, here in Italy, in Slovenia. We have so many posters. We have seen them. We have that in our faculty degrees, outside. However, we should have a system, because if we leave it like this, that could die immediately, and we cannot do that. We cannot allow this to happen. We have to use it in an organic drawing, let's say. So these are my reflections.
Thank you, both. Maura, do you maybe have any more, maybe feedback on what, if any, otherwise?
Sì, allora...
Yes. Alvisa is speaking about the facilitating factors. I think about the perception I had during these 2 years, where we had moments where nurses were close to research. I mean, I acknowledge the interest of students, because they are facing something that maybe we do not care so much about. Ethical questions, ethical issues. They reflect about the way we behave with our patients. Ethical questions are interesting for and important for students. Being close to patients increases the ability of nurses to wonder about the current situation. When nurses stay together with their patients, they have a better interpretation of reality. When they work so much as doctors, and when the teams are well integrated, they develop healthcare and clinic researches together. This is not about medical data only. I mean, when I graduated, I had Professor Palese among my teachers, among my professors, and I had a question. There's no medical research, nursing research. We only have research about issues, questions, which could be integrated or not. So we have one research. It is about methodology. Sometimes it concerns clinic issues, sometimes not. I mean, the approach is the same. And when we work a lot together, this becomes much easier. It is much easier to face problems of research. So integration is fundamental. And then we have to analyze the context where we have the highest number of research when we have data, when we have digital dossiers. If I have no evidence of data, it is difficult to think about it. Where there's instead a higher attention in these contexts, where this becomes much easier. I mean, these contexts must be the environments that we have to create, where integration is important. This is not only about figures, believe me, trust me. It is not about having a low number of nurses. This is one of the variables, but this is not a fundamental variable. So this is where we should work on.
A lot of work on many fields. So, respected Italian colleagues, I'm grateful and happy for all your reflections, since we are now here finishing the final conference in Italy. It is okay, as it should be, to also conclude with the reflection of yours, as we did. So if anyone has anything else to add, to ask, to comment, you are more than welcome. I'm inviting you to. Okay then. Oh yeah, perfect. Yeah, I'm sorry. Monica, you are, yeah. You should be faster.
It was mentioned, these think about barriers and facilitating aspects, as Professor Palese was saying. Starting from students, well, I don't know if this is done, I have no idea. Maybe we could propose the journal clubs during the bachelor's degree. So we can start from the foundations, the basis, so that these students will then go through the various working realities, and together with their interest, their approach to patients, their interest for ethical issues, they will also have interest for research. Well, I think that this is an interesting aspect. I see that there are many colleagues from the nursing degree from Udine, but also Trieste. I would like to thank them all for being here with us. This is a sign of integration as well, and collaboration. This is an aspect, an idea which is really interesting. So now we have some activities, I think, in Trieste as well, but we do not have a well-structured journal club. So this may be a path that we should follow. And then we will better facilitate things. So this may be part of the professional heritage of everyone. Thank you, Monica.
Anastasia.
Daniela Anastasia. So there's a question in the from the questionnaire that called my attention. The question is about the suggestions to be carried out in your context so as to develop nursing research and cooperation between universities and companies. So in pragmatic terms, I thought that maybe at least 10% of tutors must have a research project with their students. As I have said, 10%, but it's just provoking. I am a nurse from a peripheral hospital of this company, or 30% of the hours, training hours for nurses must be dedicated to research projects. And the main pillars must be defined by several departments. So for instance, the surgical department or others. So starting from the foundations in these contexts, Mesaglio was talking about the technicians who must help us. However, if we do not start from the foundation, the question has no impacts in practical terms. The methodology must be facilitated, not followed, I would say. And then the advice from Mesaglio that the regional policies, and we are thinking about our region in this case, have to discuss about that. But I also thought about the facilitating projects linked to additional hours, additional time linked to research projects. So maybe we have 1,000 hours of training, maybe 30% could be dedicated to research projects, maybe. These are small strategies. I thought about that, trying to find some solutions to be proposed when dealing with policies which I understand are much needed, much more needed. So we should leverage these because people should carry out research not in their spare time, but in their working time, because we should pay for it. Research has a value. If we believe and think that this can improve quality, this cannot be done for free. I'm not a trade unionist, but at the end of my career, I know that this is not about money. This is about time. Time must be promoted because we do that because we like it. We enjoy that, but we cannot do that for free. This is not against the nursing logics, I mean. Thank you so much, Daniela. Well, I would sum up this issue in ability of companies to promote research pathways. I will not focus on the tools and instruments to be used. However, building a training plan, a company training plan geared towards research and development of professionalism, of roles and job descriptions, this is fundamental because we are not looking for the results of research. The results must develop competencies, and then these will produce knowledge. So this is productive because this allows to develop the one thing that is a winning thing, which is the intellectual component. I mean, we can have resources, figures, working hours, wherever. The most winning aspect in organizations is that we are all accredited, we are joint commissions, we have some different certifications. However, the comparison is about intellectual component, and this is the winning aspect. This is not about structural certification, the process, the correct procedure. This is overcome. If our planning is our training plans are about the identification of patients and safety goals. Well, these occurs because we are still far from these results. I mean, this cannot be understood the way we are discussing about the identification of the patient. However, we have to, because in some contexts we are far from these results. Of course, it would be much more interesting to eliminate these contents of risks, anti-fire contents or BLS. However, the results that we have seen before allow us to keep some issues which unfortunately are not that interesting for professional development. BLS is a basic procedure. I should not be worried about studying it or knowing whether nurses know about this procedure. So we must be real. We must have training plans about these aspects. However, we should also make some steps forward and try and develop a percentage for training for those who have much higher attitudes. So we should not, let's say, eliminate these efforts and initiatives.
Okay. Thank you for responding and summarizing. Anyone else? No? Yeah?
The last one?
I think so.
From Bolzano, I think? Huh?
Yeah, the last one. We have 5 minutes to go to talk to this
Io
class.
sono Laura, vengo da Bolzano, sono un'infermiera.
I am Laura, I come from Bozen. I'm a nurse. There's a final reflection about the role and function of the coordinator. I mean, I am convinced that the coordinator has a fundamental role in developing and promoting research within its group, his group. And a winning aspect is to influence our own collaborators about the fact that research is a success, no matter the data emerging from research itself. And this must be celebrated. And this, in my opinion, in some contexts, is not that clear. Thank you. That's true, absolutely.
Much?
So we can
Yeah.
close now. Oh, last
Yeah.
one, Sanela, please, the Dean of the Faculty of Jesenice, Faculty of Health Science.
Okay, for finishing, I would like to thank today's the close conference for project. So I would like to thank you, all of you, nurses, participants, lecturers, our partners. What we can say at the end, what is important for all of us, nurses? First of all, I think we need to promote research. That is very important for all of us. Then, I think the nurses, of course, we hear that, need to have mentors. We need to have support by our management. I think that is very, very important. We heard today some barriers, so that is something challenge for us, yes. So nurses need to be strongly educated on this way. More we will be strongly on research. I think that we will could bring more challenges changes into the clinical area. So thank you all of you, and thank you my colleagues. I think we really do a great job. Thank you.
Now, I don't need to do anything else because the Dean of the lead faculty, Angela Bushkin, Faculty of Healthcare, concluded today's gathering. All I can say is then that on behalf of the ProCare project, I wish you a perfect Friday and the weekend. So thank you for coming.
Arrivederci.
Arrivederci.
Mandi.
Mandi.